Hi, everyone, and welcome tonight. I'm Judy Regensteiner. I'm the PhD director of the Center for Women's Health Research. I'm a professor of medicine as well, and I'm really thrilled to welcome you here tonight. We have a very good turnout, and we're delighted to have you all be part of it. Welcome to Let's Talk, Conversations about Women's Health, a lecture series organized by the Center for Women's Health Research in partnership with the UC Health organization, and for which partnership we are incredibly appreciative. 9 years ago, Let's Talk was created to educate the community about health through evidence-based talks. Each talk is created and presented by nationally renowned experts in the field. This educational series is made possible with financial support of UC Health and the Center for Women's Health Research, with the philanthropic support of our community, for which we are extremely grateful. So why are we presenting this program tonight? Well, women were historically excluded from a lot of research studies, and so there remain many unanswered questions. Women really only started being included in bigger numbers in the early 2000s, believe it or not. So there are many, many questions about women's health, which we are here to help answer. The Center for Women's Health Research is committed to research that includes women and men and accounts for sex and gender differences. We do this really to shape better healthcare for everybody. Our mission is to do the cutting edge research in women's health and sex differences, to mentor the next generation of researchers in women's health and sex differences. And this is, by the way, we have 70 young researchers, about a quarter of whom are men and 3/4 of whom are women at this point. So we're building the workforce, because without a workforce, there won't be a field. And the third part of our mission, and why you're here tonight, is to educate the public and their healthcare providers so that everyone has the best evidence-based healthcare. This evening, we'll be focusing on brain health and have a fantastic speaker lineup. We have changed the order of the speakers from the original schedule. We're going to start with Dr. Danielle Wilhour, who's assistant professor of neurology and is an expert in migraines, and she's in the Department of Neurology. Next will be Dr. Samantha Holden, medical director of the Movement Disorders Clinic at the CEU Anschutz Medical Campus, who will speak to us tonight about Lewy body diseases. And then finally, Dr. Huntington Potter, who's the founder and director of the University of Colorado's Alzheimer's and Cognition Center at the Anschutz Medical Campus. I'll be moderating today's event. I guess I am already moderating today's event. In doing so, I'll introduce each speaker prior to their presentation and moderate the question and answer session, which will occur after the three speakers have completed their talks. You are welcome to type in your questions into the Q&A box at any time during the session. So without further ado, I'm going to start with Dr. Danielle Wilhour, who joined the neurology department at the University of Colorado School of Medicine in 2019. She focuses on headaches and migraine in particular. She has a special interest in women's health, headaches and pregnancy, as well as non-pharmacological pain treatment options, including neurostimulation devices, yoga, and acupuncture. The topic of her talk tonight will be women and migraines. Thank you, Dr. Wilhour.
Hi, thank you so much for the kind introduction. So as Judy said, my name is Danielle Wilhour. I am an assistant professor at the University of Colorado, and I'm honored to begin the lecture series this evening. Tonight, I want to talk to you about a very common yet disabling condition in women, and one which I'm very passionate about. So migraine worldwide affects more than 15% of the global population, and that equates to about 1 billion people. And chronic migraine, which is defined as a migraine more than half the days of the month, affects about 1 to 2% of the population. And in the US, about 6% of men and 18% of women get a migraine in any given year. And this equates to a lifetime risk about 18% for men and 43% of women. And it is the second most disabling condition worldwide, only second to chronic back pain. And if we graph out the prevalence of migraine by gender over a lifetime, this is what we see. If we can look at males in blue and females in red. And what we see is prior to puberty, during childhood, there's an equal distribution of cases of migraines in both boys and girls. And we start to see an increase in female prevalence beginning in adolescence. And then this further increases during the 20s, 30s, and 40s, and decreases beginning in the 50s. And this prevalence, we see a threefold increase in women compared to men during this time span, during the middle ages of your life. And so how do we define migraine? So migraine is an attack that lasts between 4 to 72 hours, and it typically has at least 2 of the 4 following symptoms. So typically it's one-sided, it can have a pulsating quality, and it's moderate to severe in intensity, and it can be aggravated by routine physical activity. And the headache typically has either light or sound sensitivity, in addition to nausea as well as vomiting. And then about 20% of the population has what we call migraine with aura. And this is a fully reversible symptom that develops gradually over 5 to 60 minutes, either during when the headache starts, or a headache will follow within an hour of an aura. And this can take there's many different forms of aura. So commonly we see visual disturbances. Some people will see expanding fields or colors of light. Other people experience numbness or weakness on one side of their body, and other people experience difficulty with their speech. And I'd like to play a video, and this was a reporter at the Grammys 9 years ago.
CBS 2's Serene Branson is live at the Staples Center with highlights and backstage coverage we're seeing for the very first time. Serene.
Well, a very, very heavy rotation tonight. We had a very Darrison fight. Let's go ahead, Terrace Chase, and look for the bit. They have the pit. And the Grammy goes.
So when interviewed afterwards, this lady said she knew what she wanted to say, but she was having trouble getting the words out. And this video ended up going viral because people were concerned that she was having a stroke on air. But in reality, she was having a migraine with aura that was affecting her speech. And as you can see, it's very disabling.
CBS 2's.
Okay, and then there's other migraine subtypes as well. You can have probable migraine, which is a migraine-like attack, where you're missing one of the key features to fulfill the migraine criteria. You can have a hemiplegic migraine, which in addition to the migraine, you can have weakness on one side of the body, and there's both familiar as well as sporadic forms of this. You can have a migraine with brainstem aura, where the aura involves slurred speech, vertigo, ringing in the ears, double vision, unsteadiness, and incoordinated movements. There's vestibular migraines, where you have dizziness and vertigo, and you have a migraine about half of those times. And then there's another phenomenon called visual snow. And here's an example of it, where you have visual disturbances such as flickering dots and static, almost like an old TV, throughout your visual field. And again, as you can see, this would be quite bothersome to experience all the time. And when most people think of migraine, they think just of the headache themselves. But in reality, there are changes going on in the brain well before and after the attack. So some people experience what we call the prodrome, starting 1 to 2 days before the actual migraine. And during this, they may develop fatigue, certain food cravings, including chocolate, nausea, neck pain. They can have light and sound sensitivity. And then about 20% of people can develop an aura. And this occurs because basically of a phenomenon called cortical spreading depression, where there's an electrical excitement throughout the gray matter of the brain. And then you can experience the actual migraine itself, which we defined earlier. And then there's a postdrome syndrome, where a lot of patients report like a shadow pain afterwards, where they do not feel quite back to their normal selves, and they may still experience some light and sound sensitivity. And even between pain episodes, even during the interictal episode, what we call it, patients with migraine may be more sensitive to both light and sound, and may experience other cognitive symptoms as well as fatigue. And there's definitely a genetic component to migraines, but there's also a lot of environmental triggers as well. So some triggers include lights, computer screens, weather changes, changes in altitude, and even exercise can induce migraines. There's other dietary triggers, which include caffeine, alcohol, MSG, nitrates, aspartame, chocolate, and very importantly, skipping meals. Changes in sleep, such as lack of sleep, too much sleep, alterations in your sleep schedule. There can be psychological triggers, including stress, letdown stress, which is after a stressful week of work, and when you finally have time to relax in the weekend, you bam, get a migraine. And then there are hormonal triggers as well, and this includes menstruation, both before, during, and after menses, or certain oral contraceptive agents, pregnancy, and menopause. And I'd like to explore the relationship between hormones and headaches to help us further understand why women have more migraines than men. So we know when a woman has her first period at menarche, that the incidence of migraines rises. And we believe that this is likely due to higher levels of estrogen. So if you take these changes in estrogen, it can lead to increased excitatory neurotransmission, as well as decreased inhibitory transmission. And this combination can lead to an increased vulnerability to migraines. So if we look at a graph of the menstrual cycle, so what we see, so this blue line here is a graph of estrogen levels. So the estrogen is highest at ovulation, and it falls as throughout the preceding couple of days. And the estrogen is at its lowest level at the trough when a woman has her period. And it's really at this trough that we see an increased level in migraines, this gray graph in the back. So during menses, a woman is about 2.5-fold times more likely to have a migraine during that time. And this leads to a phenomenon called menstrual migraines. So some women can have pure menstrual migraines where they have a migraine without aura that occurs around menses, and no other migraines any other times of the month. It can also lead to menstrually related migraines where you can have migraines during your period, but at other times in the cycle as well. And how do oral contraceptives affect migraine, as many of them contain estrogen? So for some women, we may see new onset migraines. And then for other people, we can see pattern changes in their migraine. And there's a subset of women their migraines may worsen when they start birth control. And then there's another subset where they may improve with birth control. And we particularly see this in women with pure menstrual migraines. They seem to be very responsive to birth control. And the majority of women see no change in headaches. And in general, we recommend progesterone-only birth control for women with migraine with aura. And this was one study that was conducted with 102 patients that were asked to rate their headache level. And in the first part of the study, they were put on 2 rounds of classical birth control where they had 21 days of estrogen-containing birth control, followed by 7 days of placebo. And what they saw was an increase in headache prevalence during that 7-week placebo period. So then they took all of these women and they put them on a continuous estrogen formulation birth control. And what they saw was a decrease in migraine frequency. So this led us to the conclusion that migraines are more likely to occur during that pill-free or that placebo interval with birth control. So what we typically recommend is to use extended cycle estrogen-containing birth control. Or if there's a reason that you need to be on a birth control with the placebo, then you can supplement with either an estrogen patch, gel, or cream during that placebo interval. And then for the women that tend to have an increase in migraines with birth control, then we may recommend discontinuing hormone contraceptive altogether and recommend other options such as an IUD. And what happens to migraines during pregnancy? So we know that throughout pregnancy, that estrogen increases slowly throughout the pregnancy. So here in this purple line. And so what we see is that menstrual migraines and migraines without aura typically improve, especially during that second and third trimesters. So typically we see about an 85% reduction in migraines within these subgroups. But unfortunately, we tend to see an increased frequency in migraines in patients with migraine with auras. And if you do develop new onset migraines during your pregnancy, they're more likely to have migraines with auras. And what about migraine during menopause? So we know that there's, again, a subset of women who their migraines improve during menopause, another subset where their migraines worsen. And then again, the majority are unchanged. But unfortunately, about 8 to 13% of women with migraines during this age develop new onset migraines at this time. So we know that migraines are more likely to occur in late menopause as compared to premenopause or early menopause. We also know that migraines are more common in patients that had a total hysterectomy, so a hysterectomy with your ovaries removed as well. And we think that this is likely due to the abrupt withdrawal of estrogen. We also know during menopause that there's an increase in comorbid conditions such as depression, anxiety, and we see lots of sleep disturbances as well. And these are all factors that can increase migraine frequency as well. So what are some treatments for migraines? So in general, I like to recommend a multimodal approach where we work on basically lifestyle changes as well as medication and non-medication options, and we can explore all three of these. So in terms of the lifestyle, so what we recommend is eating healthy foods and regularly, so small meals frequently throughout the day, and most importantly, not skipping any meals. Typically, we recommend limiting caffeine to 1 to 2 cups per day because more than that can cause a rebound headache. Staying hydrated is also very important. You should get enough sleep, but you shouldn't oversleep. And it's important to keep a regular sleep schedule as well. We also recommend routine exercise 3 to 4 times a week, at least 30 minutes of aerobic activity, stress reduction, and keeping a diary to help identify triggers. And these are many of the same lifestyle principles that you'll hear about in the upcoming lectures in memory as well. For some of the non-medication approaches, there's great evidence and studies on all of these modalities, but specifically with meditation and mindfulness. And there's a lot of terrific apps on your phone, including Calm and Headspace, that can help you with that. Acupuncture, biofeedback, which is a mind-body technique that uses visual and auditory feedback to gain control over involuntary functions such as blood pressure and heart rate. Weight loss, because we know a weight gain can be a risk factor from increasing your headache frequency, and by losing weight, we can see the opposite effect. And exercise again. And in terms of the medication treatment options, so there's 2 different categories. So there's abortive medicines, which is a medicine that you take at the onset of migraine. So for example, like Tylenol or ibuprofen when you feel the pain. And then there's also preventive medicines. And these are medicines that you take on a regular basis to help prevent a migraine, regardless if you're having a good day or a bad day. And the preventive medicine, the goal of them is to reduce the frequency, severity, and the duration of the headache events, and also to make the abortive medicines more responsive. So typically we recommend a preventive medicine if you're having more than 4 migraines a month, if you're having severe and disabling episodes, similar to the video that we saw earlier, if you're having difficulty tolerating or have contraindications to abortive medicines, or if you're overusing your abortive medicine. If you're taking ibuprofen every single day for your headaches, then we would definitely recommend a preventive medicine at that time. There's also at level B evidence for most of these vitamins, so pretty good evidence. And a lot of people are more interested in more natural or alternative approaches as opposed to a prescription medicine. But the vitamins that have had shown that they are effective for headache prevention include magnesium, vitamin B2 or riboflavin, coenzyme Q10, another vitamin called feverfew, boswellia, and melatonin, which is typically thought of as a natural sleep agent, but there is some evidence for migraine prevention as well. There is also some neurostimulation devices that can help treat migraine. So there's one, the supraorbital magnetic stimulation device, so on the top here. And so this device goes on your forehead and activates your trigeminal nerve. And then last year there was another device which came out, and this one goes around almost like an iPad hold for your arm, and you can activate it through an app on your phone. And this device actually activates some of the ascending inhibitory pathways and can help treat a migraine. So a lot of patients are more interested in these non-medication approaches. And in terms of the preventive medicines, so historically there was 3 categories of medicine. So there was blood pressure medicines, antidepressants, and seizure medicines. And for all these medicines, we would use them to help prevent the migraine itself. And a lot of times when picking the preventive medicine, we will try and target 2 different modalities. For example, if you had difficulty sleeping at night and that was contributing to your migraines, then we may pick a medicine like amitriptyline, which can help you sleep at night and help prevent migraines. And if you fail, at least if you trial 2 of those medicines and they didn't work and you have chronic migraines, then you may be a candidate for Botox for chronic migraines. And for this procedure, so Botox is administered into 31 different sites in the front of your head, the side, the back, and your shoulders as well. And studies show that it will reduce migraine frequency by 50% and the intensity by 50% as well. And in 2018, there was 3 different injectable medicines which came out, and these had a completely novel mechanism. So they actually discovered the pain molecule, which is involved in the migraine response, and they formulated antibodies against that pain molecule. And so these are once-a-month injections that you actually do at home, and they're very effective with a very favorable side effect profile. And in terms of the abortive, so we have 2 different categories. We have non-specific pain meds and then the migraine specific. So for the non-specific pain medication, so there's anti-inflammatories, neuroleptics, acetaminophen, muscle relaxers, and different combination tablets. And for the migraine specific, so historically we had the ergots and the triptans, which were very effective. But however, they have side effects and there's some contraindications for certain patient populations. And most recently, there was 2 different classes of medicines which came out, the ditans and the gepants. So in the ditan category, there's a medicine called lasmiditan, which is similar to the triptan medicine, but it doesn't cause the narrowing of the vessels in the heart and the brain. So it's applicable to a wider patient population. And then the gepant population, so there's 2 different medicines in that which recently came out, the rimegepant and irbegepant. And these are very effective medicines. They target, again, the CGRP receptor, and they have an extremely favorable tolerability. They're described as placebo-like tolerability. So with that concludes my talk, and I hope you enjoyed it and you better understand why women are more likely to develop migraine. And by learning about migraine, we can help reduce stigma and support our friends, family, and society at large who this condition impacts. And here are some additional resources if you are interested.
Dr. Regensteiner, you're muted. Dr. Regensteiner, you're still muted. Happens every Zoom.
Thank you. I appreciate that. Thank you, Dr. Wilhour, for your excellent talk. Our next speaker is Dr. Samantha Holden, Dr. Holden is a behavioral and movement disorders neurologist and is an assistant professor in the Department of Neurology at the University of Colorado Anschutz Medical Campus. She assesses and treats patients with both cognitive and movement disorders in her clinical practice. She's the medical director of the Memory Disorders Clinic and co-director of the Lewy Body Dementia Association Research Center of Excellence at our institution. Her research focuses on better evaluating functionality and independence as related to cognition, as well as discovering new methods of measuring and improving quality of life for people with cognitive impairment. Thank you, Dr. Holden.
Thank you so much. And everybody can see my slides okay? Yes?
It's not full on, it's small.
It's small, let's see. Is that better?
Yes.
Okay, great. All right, well, thank you so much for this opportunity to speak about something that is really near and dear to my heart, Lewy body diseases, and to make sure that we're improving recognition and awareness of these conditions, because a lot of people are misdiagnosed and inappropriately treated. And something that I would hope all of you walk away from this knowing is that not all dementia is Alzheimer's, and that there are other causes, and to know how and when to recognize these other conditions. So as a broad overview of what we're going to be discussing, and also as a segue into Dr. Potter's talk, when we think about cognitive changes over the lifespan, it really is a spectrum, and there isn't a clear distinction, a clear border zone between what is considered normal, and really most neurologists know there's no such thing as normal, what is normal, in quotes, and what is considered worrisome. So for normal aging, which really after the age of around 25, things slow down in terms of processing speed and short-term memory. Some things always improve the rest of our life. The ability to recognize patterns improves your whole life, as does just general wisdom. But things do slow down the longer we're around. Walking into the kitchen and forgetting what you went in there for, that is normal. Don't worry about that. Walking out of the house and down the street before you realize where you're going, that's concerning. So if there are certain things that are changing or slowing down, but everything you're able to do day to day in your life is still fine, that's probably not as concerning. But if you are worried about your memory, if you're noticing changes, even if they're not showing up on our testing, we're still going to follow you over time, because that could be the earliest sign that you may be more sensitive to subtle changes that our tests don't pick up. What pushes somebody over into a category of what we call mild cognitive impairment? Mild, it's not so bad. Cognitive means thinking and memory. Impairment, there's some trouble. Is that now there are objective changes on our thinking and memory tests, but you are still completely independent day to day. Paying bills, managing medications, driving, cooking, cleaning, none of those are impacted yet, but there are some changes on cognitive testing. Sometimes we can find a reason for those mild changes if you're not sleeping, if you have thyroid disease that's not managed, if you're depressed, and if we treat it, we can reverse it and you'll go back to normal. Some people can stay in that mild impairment category and not progress, but then about 10 to 15% of people with mild cognitive impairment will progress onto dementia each year. Now, dementia is a term that is used incorrectly. It's become somewhat pejorative. All dementia means is that somebody has experienced a decline in their thinking and memory, and they are no longer fully independent because of it. Starting with complicated things like paying bills and managing medicines, but could progress to needing help with basic things like getting dressed, grooming, or eating. That is all dementia means. It is not a disease in and of itself. And we're going to talk about the causes of dementia, but there are many different ones, and that's what we do in our clinic to, number one, try to figure out where somebody is on this spectrum, and number two, the harder question, why? What is going on in that person's brain to cause this? For anybody in your lifetime, you have about a 10% risk of developing dementia in your life. Age is far and away the most significant risk factor for developing dementia. More than your family history or genetics, though those play a role, more than your life experiences or exposure, just living longer is the biggest risk factor. But this is not an equal risk between the genders. Unfortunately, women are at a much higher risk, almost 2 times higher than men. We don't fully understand why this is yet. It is probably a complex interplay of genetic and hormonal factors, as well as different experiences, exposures, both positive and negative. But it is not just because women live longer than men and accumulate that age-related risk. So dementia, again, is not a disease in and of itself. It just describes the level of impairment that somebody is experiencing. Is it significant enough to affect their day-to-day lives and their level of independence? Under that umbrella of dementia, for the neurological causes, ones that are not poor sleep, depression, thyroid, vitamin B12 deficiency, these are the major categories. Alzheimer's disease, far and away the most common. Between 50 to 75% of people living with dementia, it turns out to be Alzheimer's. Dr. Potter is going to talk about that more next, but it means that people primarily have changes in their memory, short-term memory first, with also trouble with orientation, keeping track of times and places and appointments. And if we were to look at the brain under a microscope, we would see little plaques and tangles in the brain cells. Vascular dementia, where there are changes in the blood vessels of the brain, either strokes or mini strokes over time that accumulate, that mainly affect the white matter or the wires of the brain, is the second most common. And then the third most common, our area of focus for this talk, are the Lewy body dementias. These are probably more likely than we recognize. And in my career, I have undiagnosed quite a few cases of Alzheimer's and re-diagnosed Lewy body. The least common is frontotemporal dementia, which we won't discuss today, but just a brief overview, mainly personality or behavior changes, in addition to thinking and memory changes, or significant changes with speech and language. So just to orient everybody to the brain, a quick overview of neuroanatomy. If I had a bird's eye view of all of my patients' brains and I could look directly in and lift the hood, my job would be a lot easier. What I do in the clinic is much more indirect. Number one, getting to know somebody. The better I know you, the better I know your brain. And I do sometimes do that to family members and friends too, and they hate it. But the better I know you, the better I understand the inner workings of your brain. And I try to understand these different regions based on how you're acting, how you're behaving, how you're performing on my thinking and memory tests, how you're moving, how you're feeling things, how you're walking. But for trying to figure out exactly why somebody might be having a thinking and memory change, there are a few regions that are implicated. The green area right behind your forehead, your prefrontal cortex, that's the most highly developed, it's the most sophisticated part of the brain. Our planning, our judgment, our personalities, our social graces all live there, really important for thinking and memory. The hippocampus, this blue area down here, which is Greek for seahorse, that is the short-term memory center. And we know that because in the 1950s, a man had both of those regions taken out of his brain on both sides, and he could never make a new memory again his whole life. So kind of a mistake that let us learn a lot more about the brain. You can get by with one, but you can't get by with none. And that is the region of the brain that's most affected in people with Alzheimer's. And then this deep purple region in here, termed the basal ganglia, is a collection of areas that are really important for movement, as well as for planning, for learning, for forming habits. And that's the region that's more affected in the Lewy body diseases. And just another view here, side on, to give you a better view of the kind of larger collection of the basal ganglia regions and how they're closely related to the hippocampus and the memory center. So Lewy body diseases is another overarching category, which means that if we were to look at these people's brains under a microscope, we would see little bubbles inside the brain cells that Dr. Lewy first saw in the 19th century and put his name on. They shouldn't be there. They're full of an abnormal accumulation of a protein called synuclein. We don't know why some people develop those accumulations and other people don't. But when you do, if you accumulate enough, the brain cells can't do their work anymore. They start dying faster than they should be just for aging. And that puts this into a category of neurodegeneration, brain cells dying. Within the Lewy body diseases, the most commonly known and recognized is Parkinson's disease. About 1 to 2% of people over the age of 60, 1 to 2 in 100, have Parkinson's disease. You traditionally think of the shakiness, that's usually when somebody's more relaxing, kind of a slow shaky that goes away when they start moving. But people are also slow in their movements, which is absolutely required to diagnose them. And we have them go through different maneuvers in our exam to look how quickly and fluidly and automatically they're moving. About 80% of people who have Parkinson's disease will develop dementia in their lifetime, which is huge. That's a risk 6 times somebody the same age without Parkinson's disease. If somebody first comes in with slowness, stiffness, shakiness, and at least a year later develops thinking and memory trouble, that is what we term Parkinson's disease dementia. As opposed to somebody that comes into our memory disorders clinic with thinking and memory changes and may have some slowness, stiffness, shakiness, what we term Parkinsonism at the same time or later, that is what we term dementia with Lewy bodies. And this differentiation is termed the 1-year rule. What comes first? The Parkinsonism for a year, then memory changes versus coming at the same time. It's somewhat arbitrary, but this is how we separate these things out right now. So the people that come to my clinic with mostly concerns about their thinking and memory, or their family or loved ones has concerns about their thinking and memory, most of them are going to end up getting diagnosed with dementia with Lewy bodies, as opposed to people that go to the movement disorders clinic worried about their shakiness, their stiffness, or their trouble walking. So Parkinson's disease, as I've already mentioned, is a movement disorder where people mainly have changes in how their body moves. Things that used to be automatic and fluid, walking across the room, picking up a glass of water to drink, things that used to happen without your conscious control in how easy and fluidly they happen, now take effort and energy. This is a hot off the press new cartoon for Parkinson's disease. On the left, there is the one that we've been using since the 1880s, which is very outdated. We have much better treatment options and we diagnose Parkinson's disease earlier so people can stay much more active and functional and live long, fulfilling lives with Parkinson's disease now. So we have finally updated the pictures and the terminology we're using. So absolutely required to diagnose Parkinson's is that slowness of movement. You can or cannot have the tremor or the shakiness. About 30 to 40% of people don't have the shakiness at first. And then stiffness of the muscles. But Parkinson's does also affect thinking and memory, as we've already mentioned. It can affect more basic things like bowel and bladder function, blood pressure, temperature regulation, and sweating. And it can also affect mood. And a lot of people with Parkinson's disease can develop depression and anxiety. For dementia with Lewy bodies, again, what comes first, movement or memory? The Parkinsonism, the slowness, stiffness, and shakiness also happens to people with dementia with Lewy bodies. It's just usually not as prominent. Again, that's not what's bringing them to the doctor, but we will pick it up when we're evaluating somebody. Usually the tremor is not there at all, and if it is, it's very subtle, and it's actually more when they're moving than it is at rest with Parkinson's disease. People with dementia with Lewy bodies also frequently have visual hallucinations, usually people or animals that they see, and at first they may know that it's not real, and maybe they'll ask, family members if they see the children in the room next door. But then as the disease progresses, people can lose insight and it can become more distressing for them over time. But really importantly, and something that I always, make sure I drill into our trainees, that if somebody develops visual hallucinations later in life, over the age of 50, and they've never had any psychiatric conditions, depression, delusions, hallucinations, psychosis, anything earlier in life, in their adolescence or young adulthood, then that is a neurological condition until proven otherwise. And most often it turns out to be dementia with Lewy bodies. So new onset visual hallucinations, usually people or animals, they need to see the neurologist. Another very characteristic feature of both dementia with Lewy bodies and Parkinson's is REM behavior disorder. REM, or rapid eye movement sleep, is the part of sleep where we're dreaming, where our brains are very active. It looks like we're awake, but our body is paralyzed. And sometimes young kids, adolescents, college age kids will wake up out of sleep, out of a dream, and they'll still be paralyzed for a few seconds because their brain woke up before their body did. REM behavior disorder is the opposite. The body does not become paralyzed at all. And then people can act out their dreams. Usually more violent, active dreams are noticed because they wake up the bed partner or the person falls out of the bed. But this is a very specific finding for Lewy body conditions. If you act out your dreams, and not sleepwalking or sleep talking, that's not in REM sleep, but REM sleep, acting out of dreams, there's about a 97% chance in that person's lifetime that there will be Lewy bodies present in their brain. They may not develop the outward symptoms or the condition that can be diagnosed, but the Lewy bodies will be there. And then the last feature of dementia with Lewy bodies are cognitive fluctuations, which are very significant ups and downs in the person's level of alertness or awareness, kind of minute to minute. Everybody has good days and bad days. People with Lewy body have good minutes and bad minutes. And again, none of these features distinguish Parkinson's disease from dementia with Lewy bodies. The only thing that does is what comes first. So getting back to those gender differences, we know Alzheimer's is much more common in women than in men. We still don't fully understand why, but we're trying to figure it out. Parkinson's disease, on the opposite side, is more common in men than women, about 1.5 times more common in men. Dementia with Lewy bodies is closer to the middle, in between the two. And this may be related to the fact that people with dementia with Lewy bodies often also have Alzheimer's changes in their brain. About 80% of people that look clinically like they have dementia with Lewy bodies, they will also have those Alzheimer's plaques and tangles inside their brain. So it's probably more of a mix of the two conditions, which would explain why the gender prevalence is more equal. So what do we do about all this? So as Dr. Wilhour already mentioned, there's some kind of common themes through everything a neurologist will tell you, where lifestyle plays a huge role in your brain's health and your brain health trajectory throughout your lifetime. The most bang for your buck will be in midlife, in your 40s and your 50s, but it's never too late to start these things. And the earlier the better. New research is showing that in adolescence and young adulthood, that lifestyle plays an important role in your dementia risk throughout your lifetime. I spend my whole day in our memory disorders clinic telling people to exercise. Exercise, exercise, exercise. Aerobic exercise, 30 minutes, 5 times a week. That sounds like a lot. Slowly build up over time. Anything that gets your heart rate up and breaks a sweat. You should be able to have a conversation, but you'd rather not. A brisk walk is perfect. What is brisk? They studied this. It's 100 steps a minute, which is walking to the beat of Staying Alive by the Bee Gees. So that is perfect. Exercise, exercise, exercise. More than crossword puzzles, more than Sudoku, more than Lumosity, exercise. In addition, there's increasing evidence for diet and nutrition, specifically the Mediterranean style diet, which is mostly unpackaged, unprocessed, as close to how it came out of the earth as possible. Fish a few times a week, poultry, avoid red meat, leafy greens, nuts, berries, beans and legumes, occasional glass of red wine and dark chocolate. You should use your brain. Nothing special about crossword puzzles. Do something that's fun, that you'll continue, where you are learning something new. There's no special answer, whatever you will do. Same goes for the exercise. Social interaction. You need to interact with others. Right now, we are all isolated, and this is a very difficult time for all of us, but video conferencing, socially distanced outside get-togethers, anything you can do to interact with other humans will improve your brain function. Sleep, sleep, sleep is huge. There's no, again, magic answer for how many hours or how much, but you should be waking up feeling well rested in the morning and then reducing your stress. It is also incredibly important to manage any other health conditions, but mostly blood pressure, cholesterol, and diabetes. With those lifestyle modifications, up to 1/3 of all cases of dementia are completely preventable. There is nothing else that has that big of an effect size that we've found so far. So that is why I spend so much time counseling people to really take care of themselves and their body, because that will therefore take care of their brains. For those other 2/3 of people for which the lifestyle modifications will help, but will not be the only answer, that is where we're continuing research to better understand why these things happen, to hopefully prevent it before people get to a point of dementia. And that's where I'll pass it on to Dr. Potter, who'll talk more about the research going on in the lab here at the Alzheimer's Center. Thank you very much for your attention.
Thank you, Dr. Holden. That was absolutely excellent. Both talks so far, just wonderful. And now I anticipate another wonderful talk from Dr. Huntington Potter, who is the founder and director of Colorado Alzheimer's and Cognition Center. He is a professor of neurology at the University of Colorado School of Medicine and internationally known for his research on Alzheimer's disease and dementia. Dr. Potter will discuss the latest research and reasons to be hopeful. Thank you, Dr. Potter. And we'll take questions after his talk.
Great, thank you, Dr. Regensteiner and the other speakers today. There have been a great introduction to the problems of aging-related and not so aging-related brain disorders. And I'm going to spend a little bit of the time talking about what Alzheimer's disease is from a biochemist and a pathologist point of view, and then talk about how we may be able to prevent such unhealthy brain aging. So the problem, of course, as we all know, is that Alzheimer's disease and other neurodegenerative diseases are becoming quite common as people grow older, care for their health, and other disorders such as cancer and heart disease are beginning to become manageable. But at the moment, we have almost 6 million people with Alzheimer's disease in the United States at a tremendous public cost, both emotionally and fiscally. About 10% of people over 65 and some 40 to 50% of people over 85 have some form of Alzheimer's disease. And as Dr. Holden said, women are about twice as likely to be either a patient or a caregiver. Currently, our main approach is to take care of people with memory problems and other neurodegenerative diseases. As Dr. Holden said, she's the director of the Memory Disorders Clinic. We have neurologists and neuropsychologists. We see about 2,500 patient visits a year. So if you have problems with any kind of neurodegenerative disease, this is the place to go in the Rocky Mountain area. And it also gives you a chance to participate in our research. So this is fine. So far, the FDA has approved 4 drugs for treating Alzheimer's disease. They're listed here, and I won't go into great detail about what they do, but essentially they allow nerve cells to communicate with each other a little bit better. The problem is they do not actually attack Alzheimer's disease pathology itself. They don't slow the course of the disease except in its clinical symptoms, and therefore we really need to do better. And the way that we do that, of course, is to carry out research. Now, the 2 pictures I've chosen for this slide show a woman on the left who you can tell has Down syndrome. It turns out that people with Down syndrome used to live to about age of 10 or 15, but now they live to be 60 thanks to better care and better consideration of their potential as individuals. But they all develop the pathology of Alzheimer's disease in their brains by the time they're about 40, and the vast majority are demented by the time they're 60. So they're an early onset form of Alzheimer's disease, which will give us insights into all the typical Alzheimer's disease that we're concerned about. Individuals on the right-hand side are some of my fellow scientists, Tim Boyd in the front and Gilbert Canus in the middle, and I'll tell you about some of their work. So let's straighten out what kinds of Alzheimer's disease there are, because that may tell us something about what the problem is in a particular individual. The vast majority of Alzheimer's disease is what we call sporadic, which means that it's not 100% genetic, it's not 100% explainable, and occurs largely in the later ages. This constitutes the 40% or so that have Alzheimer's disease over the age of 85. Now, it doesn't mean that genetics is not important. About 60% of the risk of sporadic Alzheimer's disease is genetic, and the most common cause and the most important cause of that risk is the inheritance of a form of apolipoprotein E called E4. And I'll talk a little bit about why that's a risk for Alzheimer's disease. A very small number of families with Alzheimer's disease are what we would call purely genetic or purely familial. That is that they carry a mutation in one of 3 genes that guarantees that if one person in that family has that mutation, they will develop Alzheimer's disease. Usually in the 50s, sometimes as early as the 40s or the 30s, even as early as the late 20s, depending upon the genetic mutation. If they have that mutation, they have a 50% chance of passing it on to their children. So that's why it's familial, genetic, and almost always early onset. Terrible for those families, but very, very important for giving us insights into all of Alzheimer's disease. Finally, as I mentioned before, people with Down syndrome who have 3 copies of chromosome number 21 have a very strong increased risk of developing Alzheimer's dementia, and all of them develop Alzheimer's pathology in the brain. So what is that pathology? Well, if you just take a look at the brain when it comes out at autopsy, Dr. Alzheimer immediately noticed, as shown here on this slide, that the brain of the first patient with Alzheimer's disease was smaller. But that alone was not enough to describe Alzheimer's disease. What he was able to do was to look very carefully at thin sections of the brain with new techniques and see what we now call the plaques and the tangles of Alzheimer's disease pathology. That's shown on the right-hand side. In the middle, there's a plaque, and in the bottom left is a tangle. The plaques are extracellular. They occur outside of cells, and the tangles occur inside of cells. And in both cases, they're an abnormal protein that does have a normal function, but deposits inappropriately either outside of cells or inside of cells. That's basically what we knew from 1907 to 1984, when George Glenner and Kenny Long were finally able to biochemically analyze the amyloid centers of those plaques and identify what the major protein is. We call that the A-beta peptide, and the sequence is shown there. And if you're really quick, there's a test at the end of the talk to see if you can remember it. No, just kidding. We don't even remember it necessarily, but it's a very important step to the understanding of Alzheimer's disease, because with that peptide sequence, we could work backwards and find out what the gene was that made that protein. And it turns out that it's a normal human gene, present in everybody, but happens to make the amyloid in Alzheimer's disease. Now, what does this amyloid pathology and the tangle pathology tell us about the dementia? Well, it turns out that what it has told us is that Alzheimer's disease is not really a disease of aged people. It's a disease of middle-aged people that show up with dementia in later ages. And that's because with various techniques, including autopsy, we've been able to see that the plaques and the tangles are shown here in blue for the tangles and red in the amyloid, occur some 20 years before the first clinical symptoms. That means that Alzheimer's disease is a very long-term disease, and we have to understand all of its steps in order to potentially develop treatments. Now, I mentioned apolipoprotein E, and it turns out that the reason that ApoE4 is such an important risk factor is because ApoE is a catalyst. It's a promoter of amyloid. Without it, we would not have any Alzheimer's disease. And that can be shown in mice. Normally, mice don't get Alzheimer's disease, but if you take a mutant Alzheimer's gene from one of those families that has inherited Alzheimer's disease and put it into a mouse with special genetics, then you get the mouse on the left-hand side that gets plaques. And that mouse has, for all intents and purposes, amyloid Alzheimer's disease. If, on the other hand, you remove the ApoE gene from that mouse, they still make the A-beta peptide, but they don't get amyloid. So that means ApoE is essential. Furthermore, you can test the mouse in mazes in the laboratory. Here's a typical one that we use. We call the radial arm water maze. Mice can swim. They don't particularly like to. And if they can get out of the water, as shown on the right-hand side, they like it. So that's the motivation. And mice are very good at looking around their surroundings and figuring out where that platform is. Once they've been on it, they never forget, unless, of course, they have Alzheimer's disease pathology. And then those mice don't find the platform. If you remove the ApoE gene, they don't get amyloid, and they have no trouble finding the platform. So that's our assay, and that allows us to begin to search for ways to prevent Alzheimer's disease. So for instance, Dr. Noah Johnson in our laboratory and his colleagues have taken the following simple step in the laboratory to reproduce Alzheimer's disease. They take an A-beta peptide, they put it in a test tube, and it naturally makes the filaments that are seen in the microscope in Alzheimer's disease amyloid, but it does it a little slowly. If you add ApoE4, presto, it works really fast and gives amyloid fibers, which kill nerve cells in the Petri dish. So that's our assay, and all we did was to take a whole lot of different known human drugs, one at a time, and see if any of them could block this step. And that turned out to be very successful. We started out with over 500 known human drugs. We eliminated some because they were toxic or they didn't get into the blood, from the blood into the brain. And we tested in this assay for ApoE catalyzed fibrillation. And you can see that the colored lines all slow the course of the amyloid formation. And it turns out that we have 8 hit compounds. We're very excited about them because they're known human drugs. And when we looked retrospectively at a big database of people with Alzheimer's disease or normal cognition or mild cognitive impairment, as Dr. Holden explained, we found that 2 drugs will actually increase the likelihood of people spontaneously reverting from Alzheimer's disease to normal. So that's the first step in setting up a clinical trial on these 2 drugs. Finally, I'll tell you a little bit about a clinical trial that we've just finished, which is suggestive of a new treatment for Alzheimer's disease. We've been talking about people who have a very high risk, people who have inherited a mutation, people who have Down syndrome. But it turns out that there's a special group of people who have rheumatoid arthritis, and they tend not to get Alzheimer's disease. Why? Well, at first it was thought that because they take a lot of anti-inflammatory drugs, and we know inflammation is part of Alzheimer's disease, maybe that was protecting them. But a very big clinical trial showed that that was not true. We took a different approach and looked in the blood of people with rheumatoid arthritis for molecules that might explain why they were protected. And to make a long story short, Tim Boyd and I studied a number of proteins, and we focused down on GM-CSF, short for granulocyte macrophage colony stimulating factor. Sorry for these long names, there won't be too many of them, but that one's an important one because that protein, when we injected into the mouse brain with plaques, 1 week later, half the amyloid plaques were gone. And the reason is that granulocytes and macrophages are like little Pac-Men. They run around the brain and eat up things that aren't supposed to be there, and that includes the amyloid deposits. And it turns out that these mice, if they're injected under the skin so that it affects the amyloid on both sides of the brain, these mice have no trouble navigating that radial arm water maze. So we have a treatment for Alzheimer's disease. The most exciting thing is that it may work not just in mice, but also in people, because GM-CSF is a known human drug. It's called leucine or sagramostim, and we tried and have just finished a clinical trial where we injected GM-CSF into people with Alzheimer's disease 5 days a week for 3 weeks and assayed what their cognition was and their blood tests of various kinds. And it turns out that this treatment seemed to improve one measure of memory and learning in people with Alzheimer's disease. called the mini mental state exam. They got better. And that's shown in the figure there, where at the end of treatment, people who had taken GM-CSF as an injection 5 days a week for 3 weeks actually were improved over those who only got salt water. Our blood analysis suggests that there's neuronal damage that has actually been reversed in those people treated with GM-CSF. We have a lot more work to do. We have a lot more people to test, but it's a very good start on the role to a treatment for Alzheimer's disease. It also turns out that Mahi Ahmed has been able to test people with mice with Down syndrome, and also older mice, and GM-CSF seems to improve their memory as well. So that the mice with Down syndrome actually have memory almost as good as wild-type mice, and the wild-type mice who are older get memory that's equivalent to a young mouse. We also know that Alzheimer's disease is kind of a form of Down syndrome, because we can see trisomy 21 Down syndrome cells in the brains of people with Alzheimer's disease and in mice with Alzheimer's disease, and that's shown on these 2 slides. So here's a mouse on the left side that has the mutation, and it does get amyloid, it does have problems in the water maze, and it also has cells with the wrong number of chromosomes, like people with Down syndrome. If you add the A-beta peptide to cells in culture, on the right-hand side, you can see that they make mistakes when they divide. Those 2 cells used to be 1 cell. They should have divided with 2 chromosome 21s and 2 chromosome 12s. They did it incorrectly. One of them got 3 chromosome 21s and 1 12. The other one got 3 12s and 1 21. So that's a very interesting aspect of Alzheimer's disease that we're looking at as a potential approach to therapy. And when we looked in the brains of people with Alzheimer's disease, we found on the right-hand side that they had cells with 3 copies of chromosome 21, and even on the left-hand side, the skin cells of people with Alzheimer's disease, whether it's the familial type or the sporadic type, have cells with the wrong number of chromosomes. Those cells have a tendency to die, and that's shown in the bottom, where as Alzheimer's disease develops, these abnormal cells develop to almost 20 or 30% of the cells in the brain. And then they begin to die off in the late stages of Alzheimer's disease, so that the vast majority of the shrinkage and the neuron loss in Alzheimer's disease is due to the loss of these abnormal cells. Is this true of other forms of dementia? Yes, it turns out that we and others have found this in frontal temporal dementia that Dr. Holden mentioned. We found it in Huntington's disease. We're looking in Parkinson's disease. We see it in Lou Gehrig's disease. We may find it in autism and even in normal aging. And neurodegenerative disease in developmental disorders such as Niemann-Pick disease, Sickle syndrome. I won't go through the list. They also have this abnormality. So we're very excited about this as a, if not universal, very common feature of neurodegeneration, and may open the ways to new treatments. So I'll stop there with the thanking of the team of scientists that have participated in all of this work, and the research participants and subjects in our clinical research and trials, and of course the Alzheimer's Association, the NIH, State of Colorado, and many very generous philanthropists that have allowed this work to continue. We're very hopeful that in the not too distant future, we'll be able to have a treatment that's successful for Alzheimer's disease and other neurodegeneration. We can change that horrible red line on the right-hand side to the green line, and possibly even here at the University of Colorado. I'll stop there and thank you all very much for your patience on this wonderful evening in the summer of 2020 in the midst of a pandemic. So we would have liked to see you in person, but we're very glad to see you virtually. Thank you very much.
Thank you, Dr. Potter. Everyone, please submit your questions for the speakers in the Q&A window. And I think the speakers are answering some of the questions as we speak, but we'll go through some of them as well. So thank you, all three of you, for your excellent presentations. I hope everyone enjoyed them as much as I did. I'm sure that you did. It was great to hear this important research and how it relates to clinical findings. As we prepare for the Q&A, we have a few announcements. First of all, please complete our survey. We really want to know what people think. We can only know that if you tell us, so please complete the survey. And we really do listen to ideas for future talks. We want to know how you feel about what we present, so please answer us. We are planning our next Let's Talk. Tentatively, it's for October 22nd, but that is not final yet, and we will open registration as soon as we have finalized the program. We also have a special announcement regarding our community luncheon. Guess what? We're not having an actual luncheon. As somebody said to me, I can't picture anyone in my family allowing me to go to a casual or a formal, actually, or anyway, any kind of luncheon for 800 people. So it will be virtual this year, but it's going to be very exciting, and it's going to be on November 11th. When we have Dr. Lori Santos speaking to everyone about the psychology of well-being, and in fact on happiness. She teaches the #1 course at Yale, the #1 most popular course at Yale. So she'll be a great speaker. She will be speaking to us from New Haven, unfortunately, but we have a great speaker, so it will be a great occasion. Information on everything that we present and more can be found at www.cwhr.org. That's www.cwhr.org. That CWHR stands for Center for Women's Health Research. So thank you, and let's begin the question and answer portion of tonight's program. And I'm wondering if I can be sure that I know which questions have been answered or not. Danielle, did you answer all the, or some of the questions? Or
I answered some of the questions, and those appear on the, the middle section says answered.
Oh, except it doesn't tell me which ones. Anyway.
If you ask them, I can refer everyone to the answered portion if I've already answered them.
Okay, there. Could you give us a list of over-the-counter medications for migraines again?
I put that in the answer section so you can have it written down.
Okay, this is a flaw. If you do a brain scan on someone having a migraine, are you able to see abnormalities?
So in general, so if you were to get an MRI on a patient with a history of migraines, so typically we do that to rule out other causes of headaches, so what we call secondary causes. So migraine itself is a primary headache disorder, so typically we see a relatively normal looking brain. With that being said, we can see some subtle abnormality or subtle changes, especially in the white matter. So we can see basically very nonspecific small white matter lesions. And basically, if I do see that and you have a history of migraines, that just tells me that you've had a pretty significant or chronic headache history. There isn't anything to do to treat those changes, but most of the time when I'm ordering imaging, I'm doing it to rule out other causes, such as tumors or mass lesions or something else that could be causing a headache.
There's a lot of people have asked about COVID brain fog. What do you neurologists think about COVID brain fog? Is that a phenomenon that you are now seeing?
Oh, absolutely. Yeah. It's very common, and there have been very significant neurological manifestations as well, from strokes to seizures to people being in comas from the infection itself. It does seem like the brain is affecting, the virus is affecting the blood vessels in the brain. But then there is this kind of non-specific brain fog that a lot of people experience, where it just feels like they're thinking through mud. We just don't know enough yet. There does seem to be long-term effects with muscle aches and just feeling unwell and malaise and fatigue for months, even after an active infection. But it's definitely an area we'll need to research more.
There's some indication from previous type diseases, and there are 3 clinical trials currently being carried out to see whether GM-CSF can attack COVID-19 and increase the recovery from that brain fog. So we don't know the answer yet, but we should diagnosing.
What about Prevagen? I saw a couple of questions on Prevagen. Can we have a little discussion about that?
Yeah, there was a notable absence on that slide about things you can do now of any supplement or special thing you can buy. Really, the exercise and the diet, so getting those nutrients and supplements from the good foods you're eating is much more effective than anything special you can buy. There is absolutely no evidence at all that Prevagen works. And they will claim on their commercials that there were randomized controlled trials. There were not. So it won't hurt you probably other than your wallet, but there is no evidence for any vitamin or supplement right now other than vitamin B12 if your level is low, which we always check when anybody has thinking and memory changes. But really getting those nutrients through your diet is much more effective than buying anything extra.
Dr. Wilhour, does taking estrogen for postmenopausal women have any effect on their migraines?
So if your migraines were to worsen during menopause, then sometimes I do recommend either an estrogen patch, which does a very slow, continuous estrogen intake. But in most of the time, I do a combination. I'll do the preventive medication changes, and then I'll consider the estrogen a supplemental. But it can benefit some women, especially if their headaches started during late menopause.
Let's see. What are the 2 Alzheimer's disease reversing drugs that you found to work, Dr. Potter?
Rush out and try them. So until it's published, we're going to keep them in the laboratory and still being studied. Sorry.
Well, how do we currently determine if somebody has Alzheimer's? Is there a single test, or is it a diagnosis of omission, or how would you say, Dr. Holden?
Yeah, so it depends if you're thinking about Alzheimer's as a clinical entity versus a research entity. In the clinical realm, seeing people in our clinic, getting to know them, trying to understand their brain, it is really based on hearing the story from the person living it themselves, from people that know them well. We always worry if somebody comes to a visit by themselves because we know we're not getting the full story. We need that outside observer view as well. Together with thinking and memory testing, we do brief tests in our clinic. We do more thorough 3 to 4 hours of thinking and memory testing called neuropsychological assessment. The brain scan, usually an MRI to see if there's shrinkage of any brain regions or any of those blood vessel changes in the white matter. If we want to be as sure as possible, especially if it's somebody young or it's atypical in any way or quickly progressing, we can do more specialized tests, which can involve a spinal tap, a lumbar puncture to look at the spinal fluid, and we can see signs of those plaques and tangles in the spinal fluid. And there is a newer PET scan that looks at the amyloid in the brain as well, but it is not yet being covered by any insurance. So we're not ordering that right now. But we really put together all of those pieces of information, and really getting to know somebody over time helps me much more to see if things change how we expect, anything new or different pops up. That's really the best way to determine if somebody has Alzheimer's or not. But in research, it's more defined based on those biomarkers, those signs of plaques and tangles. And Alzheimer's disease doesn't necessarily mean somebody also has thinking and memory changes yet. As Dr. Potter said, the changes can happen years, decades before somebody has memory changes. So it just depends on what your perspective is and how you define Alzheimer's.
Thank you. Dr. Potter, are there any supplements that have been shown to prevent the development of Alzheimer's at this point?
I just answered that in typing, and Dr. Holden also answered it verbally.
Okay.
No, there are no supplements that have been shown to help as yet. One person asked about ginkgo biloba, and although it's not possible to do a huge $500 million clinical trial on every possible supplement, that's one where a trial was done and it was totally without help.
Dr. Wilhour, do migraines cause brain damage if they are repeated oftenly?
So migraines can affect some of the smallest vessels in your brain. That's called the endothelium. And some of those, and with time, we can see that specifically that small vessel changes can predispose you to other conditions. We know patients with migraines have an increased risk of having stroke and other neurologic diseases. But for the majority of patients, I would say, no, it doesn't predispose you to other illnesses, but a small subset of patients can have other diseases as well.
Dr. Potter, what is the connection between rheumatoid arthritis and, and CG, what is it? GS protein.
I did that also by typing. Maybe I should just wait for you to ask the question.
No, it's hard. I'm having trouble telling which has been asked and which have not, so I'm sorry.
It exactly parallel. Yes, people with rheumatoid arthritis have an increase in GM-CSF in their blood, which is what gave us the hint that we should perhaps test it. And the fact that it stimulated these Pac-Men to go around the body and get rid of things that aren't supposed to be there. So those two facts told us we should look at GM-CSF, and that's how we all got started.
One question I have is, what is our website again? So I'll tell you again. It's I can answer this one, www.cwhr.org, O-R-G, www.cwhr.org. And somebody, the center staff, somebody is asking for where the survey is. So I don't know that either. So if somehow we can recommunicate that, that would be great. Do people with Alzheimer's have hallucinations or just delusions? And is Alzheimer's the only dementia disease with short-term memory loss occurring in the beginning?
Yeah, good questions. Short answer, no. They can, people with Alzheimer's do also have hallucinations and delusions. They're not specific for any of the specific types of dementia. They can happen in any of them. It's just that it's much more common or frequent in dementia with Lewy bodies than the others. And usually they are these very well-formed people and animals in Lewy body, but it can also happen in Alzheimer's. I do often hear from family members that they think that their loved one with Alzheimer's is hallucinating, that they thought, they had lunch with their mom who's been, deceased for a while. And there, you have to be careful and figure out what exactly is somebody actually seeing something, seeing that person there versus maybe just a false memory or kind of mixing up a timeline of what happened when. But the hallucinations and delusions can happen in any of the neurological conditions. And again, if they happen later in life and they've never happened when they were younger, somebody really needs to see a neurologist and figure out why it's happening. And the short-term memory is more specific for Alzheimer's because that hippocampus, that memory center, is more affected. And people with Lewy body usually have less of that memory loss. It's there, but it's not as prominent. Usually more trouble with what we call executive function, planning, multitasking, those frontal lobes of the brain, and then visuospatial function, so judging spatial relationships, how things fit together and navigating. But there's definitely some overlap with memory overall.
Dr. Potter, how does one become a subject in the GM-CSF study?
At the moment, the very short-term trial of 5 days a week for 3 weeks has finished. We've gotten permission to start a new trial for 24 weeks of treatment, but we don't expect to start recruiting until September. And if you go on our website, there's question that you can answer about participation in research.
Somebody asked if can we send them the answers and the questions and the answers, which is very nice. They love the answers to the questions. So I don't know, staff, if we can do that. Another question, probably, well, for you, Samantha, my husband was first diagnosed with Parkinson's because of handshaking. Did you answer this one already?
I was actually just typing as we speak, but it'd probably be faster just to say it verbally. Yeah, and this is something that comes up a lot in terms of what's Parkinson's, what's Lewy body, and people's diagnosis changing. And it's just needlessly confusing for everybody, both people living with it and loved ones, as well as for medical professionals. But again, the only differentiating factor is what comes first, and it's that 1 year rule. So if somebody was diagnosed with Parkinson's, they were shaky, stiff, slow, and their thinking and memory was totally normal. And then at least a year later, they started having thinking and memory trouble with maybe hallucinations or delusions or blood pressure changes or depression or apathy. That is Parkinson's disease dementia, as opposed to the thinking and memory changes coming first or at the same time. Now, it gets even more confusing because the category of Parkinson's disease dementia and dementia with Lewy bodies are collectively termed Lewy body dementias, plural. So I always put the S on the end so people realize it's a category. But Parkinson's disease dementia, you had Parkinson's, memory was normal, then it was not normal, Parkinson's disease dementia.
I've answered, let me see, all the questions have been answered. Well, here's another, well, I think somebody answered it. Is there any connection between having a transient global amnesia episode and Alzheimer's?
Nope. It's important to make sure you actually did have transient global amnesia, though. We do get these consults in our clinic as well. Sometimes it's misdiagnosed. Transient global amnesia is just what it sounds like, a short period where you couldn't remember anything. Really, no new memories formed at all. People repeat themselves over and over again. They often end up in the ER because people are worried they're having a stroke, and then it completely resolves and goes away. Sometimes it can recur, but does not seem to impart any higher risk of memory changes down the road or any higher risk of anything like a stroke. But it's important to make sure that's what it was and that it wasn't a seizure or something else.
The next question is, what about being totally unable to recall names past and present? I don't know how you see that. But.
Proper names of people are totally made up. So there's nothing in our brain that's responsible for our proper names. You have to affiliate that person's name with something else about them to remember it. And there's just some people that are bad at names and can't do it. So if you forget a proper name, like, the neighbor's name is Steve, that's fine. If you forget that, this is a watch, that's more concerning. So proper names, not concerning. Improper or, less specific names is concerning.
We have time for one more maybe statement. If you were going to say what you'd like people to take with them, Dr. Wilhour, what would be your parting statement?
That just migraine is a very prevalent disease. It's more common in women, and there's so many new treatment options which just came out within the last 2 years. So if it is something that you are experiencing or someone else who has experienced, please come see a neurologist or even a headache specialist, and we will help get your life back in order.
Dr. Holden.
Not all dementia is Alzheimer's. There are different causes, and it's really important to know exactly which one so that we could treat you as well as possible, but also come up with new treatments. We have to be specific for that.
And Dr. Potter.
We have great hope that there will be new treatments for neurodegenerative diseases of all kinds within the next 5 years or so. And your help in participating and learning and contributing to is very important. So we thank you for all of the collaborations that we've had.
And I thank you all for participating tonight. Again, thank you. And if I could only call for a round of applause, I would be so happy because we were in person, but we will be again, and that will be coming, and I will look forward to it. Please do complete your surveys. Please join us on November 11th for our special educational event, formerly called the Luncheon, and that will be called the Luncheon in future years. Again, go to www.cwhr.org for more information and health resources. And thank you so much for joining us tonight. It was a really great program, and I'm delighted to know that so many of you were with us. So have a good night. See you soon.
Thank you.